So a few years ago, 5 years ago, as we were looking at Healthy People 2010 data, and it was mid-course on a decade of health indicators, we look at the data and we saw that we were not really doing well in Rhode Island. Most of the data showed that we were either not moving in the right direction or we were just at the same place where we were 5 years before that. And so we kind of then, it was the big thing that made us stop, was the fact that we looked at the data specifically around children, the next generation. And we realized that if we were not changing, that generation of children, our children, had a lower life expectancy. And that was just unacceptable. So we ask ourselves, how can we do what we're doing differently? Obviously, this is not working, so how do you do it different? And that's how we start looking. So we merged different divisions. We merged folks that were focusing on chronic disease. We merged folks who were doing environmental health. And then we brought maternal and child health. And it was about finding that common language and a common framework that will bring it all together. The first thing was trying to learn from each one of those worlds, chronic disease, environmental health, maternal and child health, what was the key concept that was the unifying concept for those worlds, and then try to see how it will translate into those other universes and cultures that we're dealing with. And surprisingly, but not that surprisingly, they had common themes, even if they were not using the same words or using the same definitions, they were trying to do the same thing. So chronic disease folks were very strong on the social and environmental, starting to be very strong with the social and environmental determinants of health, understanding that disease is not just what happens with the medical care and the healthcare system, but also what happens at the community level. That was a concept that for folks from environmental health was their whole universe, and they could do that. Chronic disease folks were very strong on integration, leveraging resources, understanding that those programs, an individual is not just a diabetes, just doesn't have only cancer. You have also issues around tobacco. You are a tobacco user. You are an overweight person. So there is a comorbidity and things that needed to be addressed together. And then folks with MCH were really strong about the life course and the fact that we had those critical periods and what happens in those sensitive periods, on those moments in life, very defined moments, impacts what happens not there, but also later in life. But at the same time, you had that same concept without using the words, but understanding being used in chronic disease, because they were starting to understand, for example, that diabetes, while they had focused so much on the adult population because of childhood obesity, now they were talking about pediatric diabetes and gestational diabetes. Okay, that's life course. So you're talking about, so it was really understanding first what was unique to them, but also how you could translate that across those worlds. And that's how we got to what we are. So those were taking the time, I would say, was important. Really taking the time to understand and be able to preserve what was unique to each one of those programs. So we have a division that it's called Division of Community, Family, Health and Equity. And our division, we reorganized the division in terms of teams to really build that collaboration and internal collaboration. But it also translates then of what we do and how we partner with the outside world. So not only we have all of those different, so we have 6 teams: access to care and disparities, environmental health, we have chronic disease and care management, we have health promotion and wellness, we have early childhood, perinatal and adolescent health, and we have preventive services. And then that's internally. So outside, we partner with very key state agencies for us, the Department of Education, the Department of Youth, Children and Services, the Medicaid agency, Department of Human Services, but then there are the not so normal partners, traditional partners. It's housing, so we partner with Department of Housing. It's transportation, we partner with them. It's environmental management because of all of the issues around agriculture and food systems and so forth. So that's at the state level, and then at the community level, because Rhode Island does not have local health departments, we are it for the state, local and state. So we partner with local community-based organizations, with the community health centers. We have a direct relationship with those agencies because we do not have a local public health infrastructure. They are our local public health infrastructure. I think when I look at our programs today, both at the state and at the local level, when we started 5 years ago, I use a lot what I call the equity pyramid, and that's an adaptation from Tom Friedman's, the director of CDC, of what he calls comprehensive public health programs that need to reach all of the levels of that pyramid. And the base of that pyramid are those, it's where focus on the social and environmental determinants of health, housing, education, poverty, all of those things. When we started, most of our efforts were going towards level 1 of that pyramid, which is programs around education, counseling, or level 2, clinical interventions, that are known to be the least effective, if taken by itself, population-wide. And I must say our investments at the base of that pyramid were very limited. I think we had like probably 5 to 6% of our investments going towards the base of that pyramid. 2 years later, when we looked at the data, we had 30% of our investment going toward the base of that pyramid. So a much more balanced approach. That I'm proud of. And at the state level, so this is what we did at the local level, but at the state level is really seeing our programs truly working not in isolation, but adapting this concept. Is seeing the diabetes program focusing on the life course and expanding. It's seeing resources from tobacco program being addressed, being used to address pregnant women and tobacco use. It's seeing our folks from disabilities and health now the approaches that they use, and that's from maternal and child health, being used with adolescent health in general and with other so it's really this learning and really not merging, but integration, truly collaboration across our programs.